Okay, good morning, ladies and gentlemen. I'm Zor from Myanmar. I'm a PhD student here at the Salisbury Hawk School of Public Health. Today's topic of discussion is antimicrobial resistance from knowledge to action. AMR has been a global problem for decades, but it hasn't been a part of the global health conversation until recent years, especially issues around antibiotic resistance. So, AMR has been my interest, and as part of my study, I've been looking at the epidemiology of methicillin-resistant Staphylococcus aureus at a hospital setting. So I'm really excited to be part of this community trying to solve the AMR problem. So guest of honor, Dr. Lam Ping Min, Senior Minister of State for Health and Transport, Singapore, and our invited guest and speaker, Professor Keiji Fukuda, the Director of School of Public Health from the University of Hong Kong. Distinguished guests, ladies and gentlemen, a very good morning to you, and welcome to the Public Health Thought Leadership Dialogue, and it's a signature event organized by the Leadership Institute of Global Health Transformation, also known as LIGHT, from the Salisbury Hawk School of Public Health. Now I'd like to welcome on stage Professor Chaki Singh, the Dean of Salisbury Hawk School of Public Health, on stage to deliver his welcome address and introduce our guest of honor.
Guest of honor, Dr. Lam Ping Min, Senior Minister of State for Health and Transport. Guest speaker, Professor Keiji Fukuda, Director, School of Public Health at the University of Hong Kong. Overseas delegates, friends, colleagues, distinguished guests, ladies and gentlemen. On behalf of the Leadership Institute for Global Health Transformation, a very warm welcome to this morning's dialogue session on antimicrobial resistance from knowledge to action. The Public Health Thought Leadership Dialogue series was established to generate discussions on global health issues with various public health thought leaders. The issues discuss areas that are of specific relevance to the region, which Singapore can play a pivotal role in developing and sharing evidence-based solutions that will deliver measurable public health impact. Our previous speakers included the former WHO DG, Dr. Margaret Chan, who spoke on facing public health challenges in the post-2015 era. Prof. Dame Carol Black spoke on shifting the paradigm, integrating workplace health protection and health promotion. And as a result of that, Singapore launched the Total Workplace Safety and Health, a collaborative effort between Ministry of Manpower as well as Ministry of Health. Professor Paul Zimmert, Professor of Diabetes at Monash University, highlighted also the importance of prevention and management of diabetes in the region. In addition to organizing this dialogue series, LIGHT also publishes global health white papers to inform regional policymakers and highlight the critical importance of robust academic government partnership in addressing complex global health issues. Two such white papers have resulted from previous dialogue sessions. The first, Today's Challenges in Outbreak Preparedness, the Role of Surveillance. And the second, Evidence-Based Policy, the Role of Academic Government Partnership. We are waiting for, we're addressing our reviewers' comments and should be out in a couple of weeks. Now, as many of you would aware of, our school will be under the new leadership of incoming Dean, YY Teo. He likes to think that it's a couple of more months. I would like to think it's a couple more weeks. And under his leadership, the school will embark on developing a new vision, Vision 2025, for our next phase of growth. This new vision will not only underscore our school's commitment to impact public health at the national level, but also expand its global health initiatives to impact population health regionally and internationally. Under the school's new leadership, LIGHT will serve as the vehicle to facilitate and focus all our global health resources and expertise. Beside the dialogue series and the white papers, the lights will also bring together the regional global health projects like Total Workplace Safety and Health in Vietnam, the University of Health Sciences SPH Integrated Research Program in Cambodia, as well as the focus and possibly a specialization in global health for MPH. Following today's dialogue, we will also have the Antimicrobial Resistance program coming under light. So we look forward to this morning dialogue, and please join me in welcoming our guest of honor, Dr. Lam Pin Min, to address you this morning. SMS.
Professor Keiji Fukuda, Director, School of Public Health, University of Hong Kong. Professor Chia Ki-seng, Dean, Sosui Hock School of Public Health. Distinguished guests, ladies and gentlemen. Good morning, and it gives me great pleasure to join you at the Public Health Thought Leadership Dialogue on Antimicrobial Resistance, organized by the NUS Sosui Hock School of Public Health. I'm also delighted to welcome our overseas friends to Singapore. The dialogue theme, From Knowledge to Action, is timely as we shift from awareness of the problem caused by antimicrobial resistance, or AMR in short, to the development and implementation of actions to slow its development and spread. With the advent of modern antimicrobial treatments and advances in hygiene, deaths by infections have been drastically reduced. Yet, the evolution of microorganisms continues to pose an imminent threat to our medical advances. Often, it is only a matter of time after the discovery of an antimicrobial and its introduction to market that a microorganism develops resistance to it, often fueled by the overuse or abuse of these antimicrobials. The extreme scenario of AMR, of having no effective antibiotics to treat infections, will bring us to a post-antibiotic era where simple infections may kill. Even today, there exist infections that do not respond to many treatment options. We must therefore take action now. AMR is a multi-sectorial issue. It is exacerbated by the extensive use of antimicrobials in modern medicine and agriculture. It is also a global issue, as microbes are transmitted through the food supply chain, human travel, and the environment. The coordination of efforts between sectors and across international boundaries requires a strong will and good planning. I'm pleased to announce that to strengthen Singapore's efforts in addressing AMR, the One Health agencies comprising of Agri-Food and Veterinary Agency, or AVA, Ministry of Health, and the National Environment Agency, in partnership with PUB, our National Water Agency, have come together to develop Singapore's National Strategic Action Plan to combat AMR. Although each agency has been actively working to address AMR through its own initiatives for many years, this plan consolidates the whole of government approach required to combat AMR. The National Strategic Action Plan sets the framework for Singapore's response to AMR and prioritizes key areas of action. It identifies potential areas that the One Health agencies will work on in collaboration with stakeholders such as the public, professionals, and industry. The plan takes into account recommendations by the World Health Organization and aims to reduce the emergence and spread of AMR through the following strategies of education, surveillance, research, infection prevention, and optimal antimicrobial use. Preventing AMR is possible with the collective and conscious effort of everyone. Individuals need to be equipped with an understanding of AMR and the tools to address it to play a part in addressing the problem. The One Health AMR work group is looking into strengthening public education efforts through awareness initiatives for the general population to learn how they can contribute to efforts to prevent AMR. Activities in schools to engage our children from a very young age are also important. These can include simple steps such as maintaining good hand and personal hygiene to more in-depth understanding of antibiotics and how they work. Three key elements of all the 3 I's are essential in the longer-term efforts towards combating AMR. First, integration. AMR is not the sole responsibility of any one agency, and there's a need to coordinate our efforts across sectors. The national plan recognizes that coordination of surveillance activities and data sharing across sectors are important to improve our understanding of how AMR develops and circulates between humans, animals, food, and the environment. This in turn facilitates timely risk assessment and control measures. In human health, the Ministry of Health has been supporting surveillance of resistant infections and antimicrobial usage in the public hospitals. Hospital surveillance teams actively monitor AMR, and data from such activities have enabled the implementation control measures to prevent the transmissions of infections by resistant microorganisms. Similarly, colleagues in the food and environment agencies have also been closely monitoring our food supplies and livestock to prevent the transmission of resistant foodborne pathogens to humans through the food chain. Second, in-depth research. To understand the complex factors influencing AMR is important to develop innovative evidence-based initiatives. One example is the research project, Collaborative Solutions Targeting AMR Threats in Health System, which was recently awarded a 4-year collaborative center grant by the National Medical Research Council. This study, a collaboration between clinicians and researchers of 3 Singapore hospitals, focuses on the use of novel diagnostics, infection control strategies, and behavioral sciences to strengthen institutional and national capability in targeting drug-resistant bacteria. Lastly, international. AMR is not just a local problem, but a global one. International momentum since the adoption of WHO's Global Action Plan must lead to consensus building and action. Our domestic efforts must be complemented by cooperation and partnerships with our neighbors and international counterparts, where we learn from each other through the sharing of best practices in our collective effort to fight AMR. This thought leadership platform to learn from Professor Keiji Fukuda, who has spent years in WHO coordinating efforts against AMR, is a very good example. I'm also pleased to learn that Sosui Hock School of Public Health has put in place an institute focusing on global health called LIGHT. Under the leadership of the incoming Dean, Professor Wabaitio, LIGHT will build and expand on the school's global health initiatives to look into issues such as AMR. So in conclusion, Singapore has embarked on our AMR journey some time ago and has seen some success in our initiatives. More should and can be done. Today we have policymakers, researchers, and practitioners in this room to discuss on what is needed to combat AMR. And I wish you a fruitful discussion and look forward to your continued support as we work together to keep AMR at bay. Thank you very much.
Thank you, Dr. Lam. That's a very encouraging progress from Singapore. Next, let's welcome Associate Professor Su Liang on stage. And he is the leader of the school's Antimicrobial Resistance program. And he will introduce our distinguished speaker of today's session. Dr. Su, please.
Apologies for the delay. And I'm also very glad that to have all of you here, distinguished guests from overseas, locally, colleagues, to join us in this talk. It's my honor to introduce Professor Keiji Fukuda to come up to give this address. Professor Keiji Fukuda, as mentioned, is Director and Clinical Professor at the University of the Hong Kong School of Public Health. He has had an extensive working experience at the World Health Organization and has also led the trust of WHO in its actions against antimicrobial resistance. Professor Fukuda has been a global public health leader in many areas, including health security, emerging infectious diseases, including influenzas of all shapes and forms, SARS, MERS, and Ebola, antimicrobial resistance, and the development of the pandemic influenza preparedness framework. He has also helped to implement international health regulations, food safety, and other areas. Professor Fukuda has extensive and considerable experience in epidemiological research and field investigations, media communications, and international diplomatic negotiations, including those held to establish a historic head of states level meeting on antimicrobial resistance at the United Nations in 2016. It's my pleasure to invite Professor Fukuda on stage to give the PhD-LD address on antimicrobial resistance.
Honorable Dr. Wang, Honorable Professor Chia, and incoming Dean Professor Teo. I am absolutely delighted to be here in Hong Kong. First time in Singapore. The first time I came to Singapore was in 1977 as a student, and I've seen the city undergo a tremendous amount of change. And since I arrived in Hong Kong a few months ago, at the beginning of the year, this is the first time I've had a chance to visit the city again. So I'm really delighted to be here, and thank you for the invitation to talk. So what I'm going to do in the next several minutes is try to lay out a framework and a narrative about how do you address an issue like antimicrobial resistance. Really, what has changed? Because as an issue, it's something that's been in front of us for decades. But as you can probably tell, there's a kind of different sense about it, and there are things which are moving now and possibilities which were not really perhaps there, even 4 or 5 years ago. But to do that, let me give you a little bit of perspective. So, I did not grow up in university. I don't really have an academic background. What I really do is have a public health background, and I put these pictures up here to give you a little bit of a sense of what shapes the thinking of somebody like me. So in my clinical training, both as a resident but also, I worked overseas a bit in India, those experiences really shaped for me what is the impact of an issue like AMR. For many people, AMR is a little bit of an abstract issue. If you actually take care of patients and you see what happens in the hospitals and the decisions that you have to make, it gets into your blood. It is not an abstract idea at all. But, in going through my career and going to places like, I worked at CDC for a while and certainly WHO for a while, many of the issues I worked on were from a national perspective on surveillance systems and recommendations and how do you sort of provide a technical approach to dealing with issues. But I think that in Geneva, what I really saw and was exposed to is that how do you deal with issues which are really messy, which are not so easily packaged together. I think Dr. Heyman was there for many years, and I think he very much understands what I mean, but the world is confronted with large, messy issues, and dealing with them is really the work of public health. And so, Ebola is one of the recent examples of a major crisis that we went through, which really, I think, caused a lot of us to try to rethink through about how do we handle global emergencies like that. And so in Geneva, one of the realities of that is that it's a place where the world comes to negotiate, to talk, to discuss, and really to try to get a handle. And this kind of experience has been formative for me. So if I look at what I've learned over the past couple of decades, perhaps it can be summarized in 2 points. If you're going to work in this kind of area and do these sorts of issues, there's 2 things that you have to remember. The first, and perhaps most fundamental, is that when you develop trust, don't break the trust. This is an absolute that you have to remember at all times. The world really needs trust to solve big problems. But the second thing is, what is actually the problem? when I spend a lot of time thinking about why things fail. And part of it, perhaps the biggest reason for why things fail, is that we're not really looking at what the real problem is. And so we have a kind of mismatch between solutions and problems. And this is one of the things which has become clear to me over many years. So if we look at the context of antimicrobial resistance, one of the great achievements in human history has really been to beat back infectious diseases. So this is, came from a well-known article put out in the 90s describing mortality rates in the United States. And basically in that black line, or in the red line here, you can see that one of the big victories was the reduction in infectious disease deaths. And so now in the current period, oh, okay. So can you hear now? Okay. So one of the current, in our current period, we're increasingly focused on non-communicable diseases, but this was really enabled because we were able to reduce infectious diseases. And so one of the major gains of the 20th century. Now, when we look at that curve for the reduction of infectious disease deaths over the 20th century, of course, there are many contributing reasons. And the most fundamental has been that as countries become more affluent, as you have more things like clean water, if you have better public health, better sanitation and hygiene, the impact is tremendous. But in addition to these things, the development of antibiotics, the development and implementation of vaccines have been critical for maintaining that. And so when we look at the overall trend of the past century, what we have done is been able to reduce infectious diseases. However, the emergence of diseases like HIV in the 80s really began to increase those rates, and the warning message is clear, as was the warning message from pandemic influenza and those kinds of events, which is that don't rest so easily. These curves can go up and down, and we are able to lose the gains that we've made over the past century. So if we go to the fundamental question of what is antimicrobial resistance, we see that the answer for decades has been really two things. One is that it is clearly a natural phenomenon. In the first place, the development of antimicrobial resistance is an inevitable phenomenon. It is built into the genetics of microorganisms, and these genes can easily become expressive under the right conditions. Now, since the 1950s, it's been estimated that there have been approximately 200,000 scientific articles about antimicrobial resistance, various aspects of it. And so in many ways, we have a quite in-depth understanding about this issue. So for example, we know that there are three basic mechanisms for dealing with why bacteria develop resistance. But we also know, as we try to deal with this issue, that there are significant gaps in our scientific understanding. So for me, for example, one of the key issues is that we don't really quite understand how the ecology fits. How does the epidemiology work? What is really the relationship between the factors driving AMR in one compartment, for example, animals or the environment, and the relationship of the appearance of antimicrobial resistant infections in people? What actually are the connections? What are the mechanisms? Now, again, to go back to my first point, for anyone who's taken care of patients, AMR has clearly been a health risk for decades. Anyone who's been in training for the past 40 or 50 years has run into people with infections which are either difficult to treat to now, in many instances, simply impossible to treat. We have no options, and so we begin to see deaths from these kinds of situations. But also the implications for modern medicine as a system are really clear. One of the defining characteristics of modern medicine is that we are now able to have people who normally would have died in the past, in fact, live for many years, because we're able to do things like surgery better than we could ever do it. We have people who have immunocompromising conditions like diabetes who are able to live for much longer than they have in the past. But these are big groups of people who are at risk for infection. If we begin to lose that ability to protect these people, we really begin to see the erosion of what we think of as modern medicine. So based on that kind of paradigm, there has been an extensive effort by public health and health for decades. So for example, this just summarizes a few points and really focuses on some actions taken by WHO. But you can see that since the 1950s, there's been recognition, formal recognition of the issue, and so recommendations by different groups for studies. There's been the issuance of guidelines. There have been the development of various strategies. TATFAR is a partnership between countries on the across the Atlantic to deal with AMR, essentially on a technical level. There have been other attempts and other ways to get attention on the issue, so World Health Day and so on. And then finally, we have really increasingly see that countries and regions themselves have taken it upon to bring as much attention as possible. So the European Action Plan, the Jaipur Declaration is the declaration of, I think, 29 health ministers in Southeast Asia, again, all to begin to address this issue. If we look at the World Health Assembly resolution, which was passed in 1998, one of them, again, it highlights many of the issues that we continue to talk about today, the emergence and spread of this issue, how it's hampering treatment, costs, the need for new generations of agents, and it raises the issue of the use of antibiotics in food production. So these are all contemporary issues identified a while ago. But for those people working in the field, there has been a deep unease for quite a long time that, in fact, we weren't really making the progress that needed to be made. And in 2014, I look at this WHO report as kind of a global wake-up. So in 2014, the first survey of countries in the world was done by WHO. So 114 countries participated. And basically what this survey did was look at combinations of common important infections and common and important antibiotics used to treat them. And the bottom line is that rates were high in all regions. Variability between countries, variability between agents and combinations and so on, but the bottom line, high rates. And so if we look at something like Klebsiella pneumonia, an important gram-negative infection, 34 to 82% of the infections being reported were resistant to one of the most important groups of antibiotics and so on. Maybe equally as important, when we look at a major killer like tuberculosis, in which we know that multi-drug resistant cases and extremely drug-resistant cases are now a very big part of that problem, we see that that was underreported in many places. So in essence, when we sat back and sort of looked at everything, and at WHO, a lot of this was raised by Sweden. Sweden sent a delegation to WHO, and they met and said, we're really worried. People are not talking about this very much, but we're really worried. Can you step up and do something? And so, so this is basically the picture that we're looking at. AMR was clearly winning, and we recognize that. So if we look at the sort of the summary of the situation, we would have said, okay, there's been a lot of work done over decades to try to bring this problem under better control. We've clearly learned a lot. We know a lot about it scientifically, but we're not winning. We're losing. And so the fundamental question is why? What are we doing wrong? So, in summary, when you sort of look back and you begin to look at the overall situation, what really became clear is that on the one hand, we are dealing with AMR as a bit of a scientific issue and a bit of a healthcare issue. But really, in fact, the outlines of this issue were much, much larger than that, and we weren't really acting in that way. So, there are clearly things like we didn't have enough surveillance information. It was clear that we were not having the development and availability of new antimicrobial drugs and technologies at a rate commensurate with the development of AMR. It was clear that in medical schools and pharmacy schools and nursing schools and so on, that AMR was not being highlighted in an educational way. It was clear from looking at countries in which antimicrobial drugs are easily available without prescription that a lot of policy gaps were there. It was when the recognition of how much activity to stimulate the development of AMR was really occurring in the environment. This is now one of the emerging issues, but something that we'll have to grapple with. It was clear that we didn't really know what the economic outlines were of the issue, both in terms of doing something and not doing something. But one aspect that I want to highlight is that we still don't really understand the micro profit from AMR. One of the things which is a sensitive issue, but which is also true, is that the movement of antimicrobial drugs in all societies is frequently tied to profit. So if you are a doctor or a health system or someone who's in the community or someone who sells feed, all of this is tied to the movement of antimicrobial drugs through society, and coming to grips with this kind of issue is very hard. The agricultural aspect had been highlighted for a number of years, but I think in many ways in an unhelpful way. So a lot of blaming going back and forth. You know, you're causing it. No, you're causing it. This kind of fruitless discussion was taking place. AMR for most politicians was a zero issue, something that they had never heard about. In one of the meetings that I went to in Geneva with diplomats, I remember one of the diplomats from a country in Asia turning to me and saying, "What are you talking about? I've never even heard of this. This is a really weird topic. Why is this coming up for dinner tonight?" And the food issues are something we'll come into a little bit more. But I think that among one of the positives, and I'll be highlighting, is that there are also things going on in society. And I think that the attention by consumers about food, what is in their food, and their concerns about that are going to be one of the engines which will drive change in this area. The bottom line for me, though, is that for regular people, for just anybody, the whole acronym AMR was impenetrable. Nobody really knew what you meant. It was some kind of spaceship. It was some kind of science fiction, an abstract idea which did not resonate. If you talk about breast cancer, everybody knows what you mean. If you talk about smoking, secondhand smoking, everybody knows what you mean. If you talk about climate, everybody knows what you mean. If you mention AMR, you will just get blank faces, and this is still one of the fundamental issues. The second thing, though, is that even when you go to institutions, and this was back then to begin to talk about antimicrobial resistance, you would get a response something like this: "We understand what you're saying, we recognize it's a big issue, but it's so broad, it cuts across our entire organization. Where should this sit? We don't even know where to put this issue. How can we deal with something when we don't even know where to put it within, you can say, our sector, within our organization, but really within our society? You know, if this is a medical issue, then why should the agriculture authorities pay attention? If it's an agricultural issue, then vice versa." And so these are some of the issues which became very clear, and this was the outline of what AMR is. So if we look at some of these aspects, you know, in the United States, for example, approximately 70% or more of antibiotics are used to treat animals. And partly they're used for treatment, but really the majority of it is used either for growth promotion purposes or for, if they don't want to call it growth promotion, it may be called prophylaxis. But it is used in very large amounts. And if you look at this map here, basically indicating where are antibiotics used in the world, you can see that a huge amount of the world's antibiotics, approximately half, are used in China. Very large amounts are used in the U.S., places like Brazil and other places. But it gives you a kind of sense of how and where are antibiotics used. And in these places with large dots, a very big percentage of it is used for animals and not for people. And so this raises a number of questions. If you use that much antibiotics in animals, what is its impact? What is its linkage to people? If you are using it and you see the development of antimicrobial resistance in animals, and the food system of the world in part depends on having healthy animals, is this a sustainable practice or not? This has been a great concern of FAO in Rome. And the most important question of all, if you are seeing this kind of pattern, how can you address it? What can you actually do? So one of the stories which has received the most attention recently, sort of binding some of these aspects together, has to do with the so-called MCR1 gene, which is a gene which confers resistance to a drug called colistin. Colistin is a drug which was developed in the mid-20th century. It was used for a while and then not used because its side effects were so toxic. But more recently, it has been used a lot because we've run out of other antibiotics. And so oftentimes you hear colistin described as a last antibiotic because you don't have other things to use. The importance is that in 2016, when a group of researchers led by Liu published their article from China, what they described was the identification of the MCR1 gene, which is a plasmid-mediated form of resistance. And so other forms of resistance to colistin had been described, but based on chromosomes. A plasmid-mediated form of resistance means that it can go from one type of bacteria to another type of bacteria. And so it really got a lot of scientific attention. That group described finding it in E. coli in pigs. It was then described in being found in other animals in slaughterhouses, then in food in supermarkets, then in patients in China, and then patients in other countries, and it has now been described in over 30 different countries. And so a little bit like listening to pandemic influenza or listening to SARS, the spread internationally of a kind of infectious pattern. But, again, when I said that earlier on, a lot of the discussions between health and agriculture were not so helpful. It's really because a lot of it was focused on blaming each other. But here are some of the real issues. The world's population is going to grow by a couple of billion people over the next few decades. It is going to get much larger. And food security, the amount of food that you have to feed people, is of primary importance. It is an issue which you cannot ignore. In order to feed that many people, it is unavoidable that there is going to have to be what are called so-called intensive farming practices. And so, for example, animals will have to be raised closer together. There are a lot of bucolic pictures of having things on a free range, but for many countries in the world, this is not going to be a reality. It is clear that you can even have that kind of farming and move away from the high use of antibiotics. But the real question is, can you do that in developing countries, in poorer countries? Can you take techniques which are developed in places such as Norway or Denmark, and can you adapt them for other parts of the world? So an important practical issue. If you do that, what are the costs and impacts for farmers, for the communities, for companies, for the economies of countries? And so these are some of the underlying concerns in the agriculture sector. And then an issue which comes up is that, well, there's some evidence, but we're not sure that there's enough evidence. And so what is the scientific evidence to say that this is a very hard case? Now, another issue, of course, which you hear about is that on the one hand, we have the development of antimicrobial resistance. On the other hand, we have what is clearly a growing shortage of newer antibiotics. And so in this slide here, which was taken from the REACT group, an NGO which is focused on antimicrobial resistance, you see the timeline of the development of new classes of antibiotics. And so basically since the 80s, we have not had any new classes of antibiotics appear. So there are new antibiotics in the pipeline, but they are mainly variants of existing classes. And so we have had a breakdown, and this has frequently been referred to as a failure of business models for the development of antibiotics. And so this is also a contributor. Now, if you look at the perspective of this from industry, there are a couple of main issues. One, it is not that easy to make new antibiotics in the first place. The science is not that easy. But some of the bigger issues are that the development costs of taking an antibiotic from discovery to market has been estimated upwards to the range of a few $1 billion. It's a very expensive proposition. And among that chain, in particular, conducting safety tests can be really very expensive. And so there is a quite expensive process for doing this. And at the end, going through all of that, you may simply use the product, and it will never go to market. And so it is seen as a high-risk product. On the other hand, when you look at the sales of antibiotics compared to the sales of other drugs, here are some recent antibiotics, and you can see that the profits are on the order of millions or tens of millions of dollars. If you look at the profits for other kinds of drugs, you see that it's on the order of tens or hundreds of millions of dollars. And so there is a kind of mismatch in terms of industry's perspective. And the bottom line was clear. A lot of companies simply said, this is not a very good equation. We don't really want to be in this area. Why are we going to do that? So currently, in this area, there have been extensive efforts done both by countries and organizations to revitalize the development and production of antibiotics. You know, under David, Chatham House, for example, had a discussion on antibiotics and production in London some years ago, and I think a very fundamental discussion took place then. In the current world, much of the attention on this issue really focuses on so-called push-pull incentives. So a push incentive is, can you provide enough money to stimulate interest in manufacturers to make drugs? And so things like CARB-X and IMI and so on are really focused on these aspects, as well as throwing attention on pull mechanisms. If you have a licensed product, what is it that's going to incentivize? What is it that's going to pull the product along so that you have enough in the way of financial incentives? But I have concerns about this current approach. I'm not sure that it's really sustainable on a long-term basis. Are governments going to continue to put in hundreds of millions of dollars and simply say, we are going to take it on to stimulate? Are they going to keep providing some kind of mechanism for pull? Again, I have my doubts here. There are some other fundamental issues which have been raised. The difficulty of antibiotics is that on the one hand, you want to stimulate development, you want new antibiotics, and then you want to use them as optimally as possible. You don't want a lot of people using them unless they need it. This is not an interesting proposition for companies because, if you make a new product, of course you want to get it out there. You want a return on investment. And so this is a kind of dilemma. And so there has been a lot of discussion. If we're going to keep rates of AMR as low as possible, you need to delink profit or revenue as a motive for distributing these drugs. But how do you do that in the current paradigm that we have? And so a lot of discussion that we don't have the right business models. And we don't have the right business models. And I'm not quite sure what that right business model is, but I do believe that it will be some kind of public-private partnership in the way that we don't have right now. The second issue, though, in negotiating on AMR and in trying to get a global consensus about what we do, here is where you begin to see that the interests of all countries diverge a little bit. For many of the poorer countries, the issue is not so much the development of antimicrobial resistance. It's simply the issue that we can't get access to antibiotics. We have people dying from infection. If you're talking about resistance, we have a more fundamental issue. How do we even get a hold of drugs that can be used? How do we gain access? And this issue of access dominates public health discussions in one form or another over and over again. And it is one of the fundamental public health issues that we have to someday find a solution to. Now, environmental contamination is an issue that you're going to hear more and more about, and I believe there'll be more research about, and it's a very important compartment. On the one hand, it's clear that the genes for antimicrobial resistance way antedate the availability of this group of drugs. And so, for example, you can find genes conferring resistance to vancomycin, which are obtained from permafrost, which is 30,000 years old. The importance of this compartment is that it both is an incubator for antimicrobial resistance, and it's also a compartment in which a lot of horizontal gene transfer can occur. So from bacterial species to bacterial species is really facilitated by that. So that is a natural phenomenon, but what is happening is that it's really being intensified by human practices. And so, for example, if you look at wastewater from a number of countries or streams, you can document measurable to significantly measurable levels of antibiotics. What you find is that contaminated wastewaters will come from point sources, so antibiotic plants, or hospitals, or clinics, or where people are being treated in communities, and so on. And so you have this large stimulation of the environment which is going on, and traditional wastewater processes don't really do a very effective job in getting rid of many of the antibiotics out there. And so the same question comes up. If this is happening, how important is it, and what is the relationship of what's going on in the environment to what we are seeing in terms of patients and hospitals? So anyways, many of these things really led to consideration in the change of strategy, and basically what became very clear was that we needed to move away from a strategy focused on scientific and medicine really to much more of a whole society approach. But the question became, okay, that's nice, but how do you actually act upon that? And so one of the things that we decided that we needed to do is really go to a top-down approach. There's often discussions about top-down, bottom-up, or doing both of these combinations, but the issue of the top-down was that it was the fastest way to begin to cut across sectors and get sectors together. And in this process, there were a number of actions and people who were important. So in terms of individual champions, which is what you need to move issues, you need individuals to step up. We had ministers from Sweden, from Norway. We had the UK government. We had people like the chief medical officer. We had people like Jim O'Neill, really individuals who took it on to really push this issue. They were a critical component to all of this. The Global Action Plan, which I'll describe why, reports by Jim O'Neill, who's an economist, and then, just a paragraph from the G20 when it was in China, and then finally the UN high-level meeting. The Global Action Plan was requested by the World Health Assembly in 2014, and we delivered it in 2015, a written plan. And to develop a global plan and to deliver it and get it passed within a year is really a very short time frame for global issues. The reason why it was possible, though, in this instance is that there really was a cross-sectoral work, working with colleagues from the Food and Agriculture Organization, as well as the World Organization for Animal Health, OIE, really began to pull together a multi-sectoral effort. Now, the plan itself is really a technical blueprint. It's basically what to do. So you'll see things like surveillance, guidelines, these kinds of things. There's really nothing startlingly new in it. It encapsulates principles and approaches which have been developed over years. But what was really important about this was that it was really predicated on the idea that we needed to do it in a multi-sectoral approach, as opposed to approaching it simply as a health issue. The second thing which I see is really pivotal in there is that there was a lot of listening to poorer countries. And poorer countries were basically saying, we cannot move as quickly and we cannot start in the same way as rich countries. We need a stepwise approach. And so that is really built into it. And so there's a kind of recognition that where you come into AMR is not going to be the same. The adoption of this of this report by WHO, by a governing body, was absolutely critical for getting this discussion to the United Nations, because the United Nations needed a consensus in another body. It needed a document to be able to do what it had to do. Now, the review on antimicrobial resistance was a series of reports. It was commissioned, this whole body of work was commissioned by David Cameron when he was the Prime Minister for the UK, and supported by the Wellcome Trust. And basically, it was a series of reports looking at AMR, but not written by a health person, but by a famous economist. Jim O'Neill had been the chief economist at Goldman Sachs, and in analyzing it from the perspective of an economist and proposing action, what this really did was get the attention of other economists and made it a credible issue in the financial sector. And it was one of the bases for why the G20 would say this is an issue that we can take a look at. Now, the G20 is a very hard group. This is a group which looks at finances. It doesn't even really like to look at issues like development. It is a very hardcore group. And so for them to actually talk about health issues inside any of their communiques is really surprising. But because of this sort of growing consensus that we had an economic issue as well as a medical issue, we had a social issue, when the G20 leaders issued their communique, met in Hangzhou, China, and issued their communique, they put a paragraph in there on antimicrobial resistance. It was beyond what we expected, but this was also a critical piece. So in this process, building up to the UN high-level meeting, what was the binding glue for all of it was recognition by everybody that we had an issue of a very big magnitude, and it was an issue which everybody could understand. Health has one of these inherent advantages. It is something that everybody understands and it's relevant to them. There were a lot of differences in the discussion. How important are regulatory mechanisms, for example? Some countries pushing for hard mechanisms, others saying that no, this would not be good. Timing, how quickly to move on different issues, discussions about who is responsible, stewardship, issues on access, the importance of access versus the development of drugs and so on, and then of course a lot of agriculture-related concerns. But again, one of the key factors for binding everybody was the Sustainable Development Goals. The Sustainable Development Goals are really the product of one of the largest global discussions ever. And in many sense, it is the world's aspirations of how to be a better world. It's related to development, it's related to education, poverty, health. All of these things which we hope for in a better world are really conveyed there. And for countries, this is quite an important thing. And what became clear in discussion was antimicrobial resistance poses a threat to the ability to actually implement these things. And there are many ways to explain this, but I like this slide the best. If you look at the cost of treating one patient with drug-resistant tuberculosis, and you look at it in comparison to the treatment of people who have sensitive or easily treatable tuberculosis, you can really see the kinds of resources that you need to put into an issue like AMR, which in many ways the countries are wasted resources. So in 2016, the United Nations took on antimicrobial resistance, and it was really a historic discussion. It's only the fourth time that the United Nations has addressed a health issue. So the United Nations has addressed HIV/AIDS, it's addressed non-communicable diseases, the Security Council addressed Ebola in an emergency session, and this is the fourth ever discussion on a health issue. And so the potential for that meeting and that kind of attention is something that we have to act upon. And so it's one of the things that I think about a lot, because the window of potential really shrinks very quickly. And so what can you do when you have that attention? So if we look at the situation and say, okay, we've now had that meeting, we've now had a much broader range of attention than we've ever had in the past, what are we actually going to do? How are we going to move on this? So I think the first thing to recognize is that what we're trying to do has not changed through this whole discussion. So we want to have the lowest sustainable levels of antimicrobial resistance. We do want to have the reliable development and production of essential technologies. This includes things like the diagnostic tests as well as medicines and so on. And it has to be affordable, and it has to be equitably affordable. I mean, these are the ingredients for a global issue to really have global support. So then if we go back to that slide where you saw a lot of different problems, we can begin to group it into what are the things that we need to address. And so for me, if I were to sort of set them up and what I think we can do sooner rather than later, it would look something like this. I think that there are a number of issues which are foundational. The effort to explain AMR in a way which makes the issue relevant to people so that it's understandable is absolutely critical. We're not going to get that far if it remains an abstract issue. I think that there has been a huge amount of research, but what we need to do is shift the research and identify what are actually the policy issues and the policy actions which are needed. What is the evidence to support them? And that this ought to be policy-driven research. So, for example, I believe that we have as a priority what is the role of the development and the development of AMR in non-health sectors. And I think this is going to be one of the keys for moving policy in the environmental sector, in the farming sector, in the food sector, and so on. I think that there is clearly growing awareness in a number of countries and regions about food and antibiotics, antimicrobial resistance, and so on. I think this is something that should be facilitated. And then, of course, there are a number of technical actions. We don't have good mechanisms for monitoring trends globally. We have it in some countries, but we don't have it globally. So surveillance remains a high priority technical issue. Issues like moving this into training of physicians and health workers, this is a low-hanging fruit. It's something that we need to move on. The second issue is that we've made headway on multi-sectoral ownership, but in the end, this is, again, one of the foundational issues. It's not going to be addressed by the health sector alone. It's not going to be addressed by agriculture alone. It's not purely a financial issue. If there is not a kind of multi-sectoral ownership, we're not going to be able to address this kind of issue. The good thing is that we have a lot of problems, and the same dilemma is there. If we don't find the mechanisms and the right approaches to multi-sectoral ownership, we're simply not going to be able to grapple with the problems of the 21st century. There are, and it differs from country to country, a number of policy gaps where legislation is needed. It may have simply to do with getting access or reporting and so on, but we need to fill those gaps. But below that, I think we have some very difficult issues, and I think agriculture issues are one of them. I mentioned that we have the questions of food security and food supply and the need for intensive farming practices. How are we going to technically make that possible in all countries in the world and so on? What's needed? What are the economic concerns raised by them? Right now, Codex is the mechanism, the global mechanism by which food safety standards are set, and it is de facto the standards which are adopted by the World Trade Organization. So this is, again, a very critical area to get the standards for how much antibiotics can be in food and so on right. It's a very sensitive topic right now, and I'm not sure how quickly we'll make progress in this area, but it will be a critical area. And then the whole issue of development. What are going to be the public-private business models which are going to get us, into the future? The most fundamental issues, however, I think are even below that. I think access is going to be one of the difficult issues, and I don't know how we're going to crack that, but this is one of the fundamental issues underlying antimicrobial resistance, but a whole host of other global issues. And then finally, in a sense, we need a kind of paradigm change. It was interesting in Geneva, at the World Health Assembly, 2 countries sponsored a meeting on antimicrobial resistance some years ago. One was Sweden, which is not so surprising given their interest, but the other country was Ghana. And the health minister from Ghana was asked, why are you doing this? You have so many issues. And the health minister said, look, I've had to close a number of different hospitals because of this issue. This is a development issue for me. And we can't continue this way. We cannot, as a country, continue in this way if we're going to have this kind of problem. And in that meeting, there's a lot of discussion that if we continue to think of things like antibiotics as a commercial product only, we're not going to make that much headway. It is a kind of product where the concept of it as a global good is really somehow inherent and somehow important, and it will be part of the long-term solution, I think, for this issue. But how we make that transition will not be so easy. And so, in summary, moving top-down is really a starter. It was not the end of anything. It was really just a way of starting this whole process. Bottom-up is the engine. This is really the engine. This is why things change in the world. And so, just to give you some examples, if you think about the emergence of HIV as a kind of esoteric infection in the 80s, to an issue which has completely changed the medical paradigm about what patients expect, what physicians expect, about how we look at the distribution of medicines and so on. This was really a bottoms-up paradigm change. Same thing for tobacco control. You can now have bars which don't allow smoking. This kind of transition was not possible in the 50s. It became possible because smoking became a social issue. Same thing with climate. No matter where you go in the world now, you only have to mention that the weather is changing and we need to do something about it. So even if one country says it will step away from the table, everyone else is saying we're not stepping away from the table. This is the kind of social energy you need. If you look at something like cancer, it is so heavily supported because people understand at a very much grassroots level what this means. So I like this slide because it's one of the slides that we used to give a talk at the UN in preparation for it about explaining what we were trying to do. And so, again, if you move away from strategy and technical and, these kinds of things, and you simply say, what do people really care about? I think it comes down to this. They want to have health care which is affordable and it's effective. So if you get sick, you want to go and you want to be treated and you want your family to be treated and you want it to be good. If you're going to have a baby, you don't want to have to worry about complications. These are the things that you want. And if you're going to eat food, you want to make sure that you have enough food and you want to feel like there's nothing hidden in it. It is simply food that you're eating. It's not food plus antibiotics or food plus resistant organisms. And, this is really summarizes, I think, how people can understand this issue. So, if we're going to deal with a large issue, and AMR is a very large issue, then I think we have to think about it really as a social issue. It is not a health issue. It is really a social issue. And I think this means that we begin to think about, even beyond whole of government, what is the whole of society approach to large issues. So, we can't just leave the discussion at that level. We do need to talk about specific goals and actions. And so for me, I broke them down into where I think we need to focus immediately. But the real goal is to get whole society engaged in this discussion. So thank you, everybody.
Thank you, Professor Fukuda, for sharing your insights. Ladies and gentlemen, before we start our panel discussion, please join us and thank Dr. Lam Ping Ming for creating this event. Moving on to today's panel discussion, let's welcome Dr. Sudi Yang on stage, and he will to introduce the panelists.
Can you hear me? Great. Now, before we start, I know some of you have not come to this pod dialogues before. And I think it can be a bit less formal now that the front seats are relatively empty and the media seats are also relatively empty. What happens is that I will invite 3 other distinguished panelists to join Professor Fukuda on stage, and they will each get their turn to discuss what they had thought to say about AMR and about Professor Fukuda's speech, after which the actual dialogue will be open to the rest of the floor and obviously between each other. So we are very happy to have 3 distinguished panelists to join Professor Fukuda. The first needs almost no introduction. Professor Vernon is an almost ubiquitous presence in infectious disease in Singapore. He's the director of the Communicable Disease Division at the Ministry of Health, and is also an adjunct faculty with us at the School of Public Health. He is the chair of the work group that has come together to put up the National Action Plan on Antimicrobial Resistance, and it's certainly good that we have him here. Our second panelist is Professor Patricia Conway. She is a microbiology and immunology specialist working at the University of North South Wales, and she spends quite a lot of time now in Singapore at the Nanyang Technological Institute. Our third speaker is from our own faculty, Professor Helena Legido-Quigley. I hope I got the name right. She is an expert on health systems research, and she has done extensive work on health policy and health systems both in Singapore and in the region and internationally, and we are quite glad that she decided to put some of her attention on antimicrobial resistance. So please give a hand to the panelists. We'll start with Professor Vernon Lee. Do you have anything much to say at this point about the National Action Plan now that you see it finally announced and about what Professor Fukuda has said?
I think Senior Minister of State Lam has already presented the launch of the action plan, and Professor Fukuda has said all there is to say about AMR, so there's not much else to add. But I think a couple of points that we would like to emphasize. One is that it really takes collaboration between all the various stakeholders, and it's really a One Health and beyond approach. If you look at how we've taken that same approach to developing the Singapore's National Strategic Action Plan, is very much built on the foundation and the work that has been existing in Singapore for many years now, done by the various One Health agencies. And when we came together to develop the action plan, it was actually a progression, a natural progression, and very close collaboration with all the One Health agencies that are here in the audience today. And we really felt that it is important for us to come together to coordinate our efforts, because it is not the effort of any single agency or any single individual. Then going on to the part where we need to bring in different stakeholders. So it's not just government agencies. We have to bring together academic institutions to do more research into what are the contributing factors to AMR, especially also the social behavioral factors. We have to bring together the community, so whether it's patients, professionals, and etc., to work with us to combat this problem. And then beyond Singapore, we have to go then regionally and internationally to work with our various partners across the world to ensure that AMR is controlled across the world, because whatever happens somewhere else in the world will unfortunately come to Singapore and many of the other countries that have very, good travel and trade links. So I think that's all I want to say.
Thank you, and good morning, ladies and gentlemen. And it certainly is a pleasure to be with this esteemed group, and what an excellent presentation. And thinking this morning on some key points and aspects I would like to raise. I think you ticked all of the boxes. So I think there's not a lot, nothing new to say, but rather emphasise and confer with you in your comments. And I'm working at a university situation and a microbiologist in training, so therefore my focus will be on the food and agriculture side of the aspect. And I was actually in Sweden at the time antibiotics were cut out of animal feeds, and therefore part of trying to find alternatives to antibiotics, and spend quite some time looking at food, trying to alter the food perspective on the animals. But at that time, the community at large and the scientific community wasn't ready to accept alternatives to antibiotics. So perhaps at the end of today, that might be a question I could pose to you, is that in addition to antibiotics that are killing, Can we have compounds that may be making us more resistant to the presence of the undesirable microbes with the antimicrobial resistance? And can dietary means improve our health so that we're, and trigger our immune system? And that's my immunological background coming in. But first of all, let's look at where I am at the moment at NTU and the NAFTEC. It's a food technology centre. Is we're looking at the antimicrobial resistance in the farm to plate concept. So it's from the farm and the antibiotics used in the agricultural. And as you've clearly presented, the biggest use of antimicrobials is in the agricultural sector. But it doesn't have to be, because in Denmark back in '98, they banned the use of antibiotics in animal feed, and especially pigs and chickens. And as expected with pigs, there was an increase in mortality and disease and a decrease in the weight of the pigs for about a 3-year period. So by about 2004, there was a greater incidence of disease, but now even by 2006, 2008, the figure had totally reversed. The pigs were healthier, weighing more, lower cost, and significantly less death and no antibiotic usage. So it is achievable, but as you mentioned, it's a cost factor, because to change management practice in the agricultural field does initially require an input of capital to alter practices. It also does initially result in an agricultural loss for the farmers, because they're going to have perhaps less weight of pork being sold. So if there's some compensation could perhaps occur for this. Getting into the food chain, I often hear, and I'm not Singaporean so I can make these comments, I often hear that Singapore is a small country and we have to import all of our food. But Denmark is also a very small country, and the Netherlands. And the Netherlands is seen as an agricultural bowl, as a source of food, but in fact there's more food goes through the Rotterdam port in the Netherlands than comes into the Singapore port. So Singapore, it's not novel. There are other countries with very similar issues and aspects importing their food. Within Singapore, the possibility of increasing food production, we have the agriculture, the aquaculture, and the agriculture is the Asian green vegetables. If that can be, and I know there's a very active program here in Singapore now to produce vegetables without any antibiotic contamination, and also the chicken industry here in the egg industry. There's very high quality chicken and egg production already happening in Singapore, and by addressing the processes used for the production, we can reduce antibiotic usage. So let's then take a look at the role universities can also play in drug development, because, and I was fascinated by the lack of new antibiotics that are coming onto the scene and being developed. And perhaps this is partly because it was heavily left with the pharmaceutical companies and your concept of the cost of bringing them through. But we also need to flag that they could spend all that money developing new novel antibiotics, but then they become resistant in perhaps 6 months. So all that investment is gone, or by the time they get it to market, because of all the testing that needs to be done to get a successful product, they're already getting very close to the end of the life of their patent. And so therefore the probability of making profits from that is also an aspect to be considered. So dollars across the board are important in this aspect. So I'd like to finish by making a comment on, do we need to kill the bacteria all the time? Or could we find other means of removing them from the agricultural scene so that there's less of a need for the development of antimicrobial resistance? And why I say that is, I'll use an example. One of the pathogens that colonizes the gastrointestinal tract and carries through to, or a number of them, through to the food and carry antimicrobial resistance with them because they're gram-negatives, have these little hairy appendages that allow them to attach to the system and stay there and multiply. If you can simply put in receptors that inhibit those appendages to allow them to attach, you don't kill it, it gets flushed from the system. So I think we need to also look at novel developments in reducing the need to kill every bacteria, but rather remove it from its location. And I think universities play a very important role in this process because we're multidisciplinary. We've got brilliant chemists and and drug delivery systems and ways of delivering the drugs so that they're effective where we need them, rather than, and as a gut microbiologist, many of the antibiotics are oral. So you're killing everything there, including some of the good ones you want to keep. So I think we do need a multidisciplinary approach to finding not only new antimicrobials that are going to be killing, but other approaches and triggering the immune system. So perhaps I'll pose a question to you as to, can you see a bit of a rethinking in terms also of the types of compounds that are being used as antimicrobials?
So one of the most interesting talks that I've heard recently about AMR was given by a representative from one of the large chicken companies in the US. And basically they said about 15 years ago they had identified AMR as a company priority. So the question of course came up, why? I mean, 15 years ago. And he said, well, we began to get letters. And the letters were not so much about AMR, but if you're using antibiotics, do you have a lousy product? You know, how come your systems are so bad that you have to treat all your animals with antibiotics? And they said based on that kind of inquiry, they began rethinking through how to raise chickens. And so part of it had to do with things like what products. So can they use probiotics, or can they if they alter the feed, does it change how animals get infected and so on. So, I'm not really expert in the different kinds of compounds and those kinds of things, but I was astounded at the amount of rethinking that they had done on the entire system. So yes, I think the answer is very much the current way that we think about production and so on can be rethought through. I think a lot of, you will certainly know this area better than I, but I think that different compounds to address both prevention in terms of food, but other products as well as treatment are all possible.
Thank you. Helena, your own perspective on things.
Thanks a lot, and good morning, everybody. It was an honor for me to be a discussant after Professor Fukuda's presentation. And I just have to warn you that I'm coming from a little different angle from the rest of the speakers, but most of the issues that you've mentioned, they were also raised in my field or the type of work that I do. So just to mention that, as Jung said, I'm a health systems researcher and health policy, and I do some work on global health. And I have to admit that only recently, I think in the past few years, we have been interested in AMR work. So most of us have done a lot of work on HIV, NCDs, and suddenly we were asked, what are you doing about AMR? So, and even in other places where I collaborate at the London School of Hygiene, I have colleagues working on health systems research, and we were like, what is AMR? Shouldn't we be doing some work on this? So I was very lucky to work together with Jung, and I'm part of the MRC Center, and I've started doing some research. So the bad news is that I've only started around 1.5 years. The good news is that because I've done research on other areas such as NCDs and HIV, I think it's important that we can take some lessons from those movements and from those public health threats to AMR. So that's how I'm going to reflect today on my key points, which I have about 5 key points and 1 final reflection. Also to mention that I will combine some of the preliminary findings because we are doing some research on. We've done some interviews with global health actors, and we've asked them about challenges and key priorities. So most of the topics, they're quite similar to what you've mentioned, but some of them, they come from a different angle. So the first and key, terminology. That was very clear. What is AMR? And I think I found it very interesting to see on one of your slides that you have to say, what is AMR? I don't think you would have the same experience if you were talking about diabetes or you were talking about HIV. It gets a bit more complicated, and I'm sure you're all aware. Now there is also this other terminology, One Health, and now even planetary health. So it's like, how do we actually conceptualize it? And I want to give you an example from one of our interviewees in Singapore, because I'm also doing some interviews in Singapore, and I was talking to a healthcare professional. He's identified as an expert by Liang, And I go and meet him, and he says, "Oh, I'm sorry, I don't know much about AMR." And then I start asking him questions, only to realize that he is an expert, but he was framing it in a different way, as infection control at the hospital level. But for him, AMR was, I'm not sure I know much about what AMR means. So I think this is very important to take it into account. And what can we learn from the NCD world on that is that, if you think about it, NCDs is non-communicable diseases. To make it a global issue, it was also a challenge having this terminology. And now some people are arguing that maybe perhaps we should move to chronic conditions that people understand better. So I think with AMR, we also need to think about that, of how to frame it. The second point, and I think this is the most controversial point I'm going to make, it's around the issue of priorities of developing countries versus developed countries, which Professor Fukuda has mentioned. But some of the interviewees are starting to challenge a bit the priority of donors. So they're saying, okay, donors have very certain priorities, specific priorities on AMR, and they're actually thinking that it's more important to invest on new antibiotics, on new technologies, rather than the real needs perhaps from the less developed countries. So while there is an awareness of the difference between developed and less developed countries, at the end of the day, if donors try to match the priorities, we need to find the balance there. The third issue, and this came up in a few interviews, and I think it didn't come up in Professor Fukuda's presentation, there is a bit of a debate now into whether we should be investing into new antibiotics or new vaccines. And not only that, of whether we should be actually increasing coverage of these vaccines, because they could dramatically reduce the use of antibiotics. So this is another area that came up in the interviews. Finally, or two more points linked: implementation and the role of civil society, which has been mentioned, what we learned from HIV. Implementation side of things, whilst everybody acknowledges that countries are developing national AMR plans, there's also a sense of maybe we do have too many priorities. Wouldn't it be better to have 2 or 3, and we go towards achieving that as a starting point? So this is not my views, this is interviewee data. And the other big issue, the role of civil society on AMR. We did see with the HIV response that we moved from millions to billions of funding because civil society was key. And patients were key, and actually they were involved in many of the decision-making processes, which I think for AMR is still not the case. There are a few NGOs, like the one you mentioned, REACT, but the role that patients, the community, and NGOs play, it's not very clear. One of the suggestions from interviewees is why not play an accountability role for the implementation of the national action plans. So that's one of the areas that was mentioned. As I said, very much preliminary findings, and the final point that I want to make is more echoing Patricia's comment on the need for a multidisciplinary approach, and the fact that this meeting really facilitates this type of discussions. And I'm very happy to be able to be discussing with Patricia, because we have completely from different backgrounds, and we can really complement the work that we're doing.
So if I can just add to that by saying that I'm sure all of you are very excited to know about what's in the content of the National Action Plan, and which encapsulates a lot about what the discussion and thinking has been so far. So the action plan, I believe it's already been or will be loaded very soon onto the Ministry of Health website and on the websites of all the various One Health agencies. So you can go there, you can download the plan, and you can have a look at it. But basically, I just want to mention again the core strategies that SMS Lam had mentioned earlier, and that brings together a lot of the thoughts that had been presented. So I think one of the important points is on surveillance and risk assessment. And the whole purpose of surveillance and risk assessment is that if we don't know what the problem is, we can't really deal with it. So first and foremost, we need to understand the extent of the AMR problem in Singapore and across the world, and then to see what is the risk that it poses across the various sectors, and then we can look for solutions. Research, as mentioned earlier, plays a very important role in this. Research to develop better methods for detection to enable surveillance, research to look for novel solutions to tackle the problem from a social behavioral aspect, or the discovery of new drugs, new antibiotics, or even vaccinations to prevent infections from starting so that we don't have to use antibiotics in the first place. Then education. Education is the other important thing that I've mentioned earlier, that we all have a part to play. How do we educate the public to understand when and the need to use antibiotics, and also professionals to be able to advise the public on the patients and also the animal health sector on when is the best time to use antibiotics in an appropriate fashion. Next, we have prevention and control of infection. So as I've mentioned, if we can prevent infections, then we will not need to use antibiotics in the first place. So through this, we have initiatives in the hospital level in terms of infection prevention and control. We have also recently launched the National Adult Immunization Schedule, together with our childhood immunization schedules, enables individuals to be protected against common diseases so that they will not have to use antibiotics against them. And finally, optimization of antibiotic use. How can we use antibiotics in the best manner possible to achieve the outcome of being able to deal with infections when you need it, and at the same time not promoting antimicrobial resistance from overuse or abuse of antimicrobials. So I think this basically is the whole national action plan, and we'll definitely look to hear the views of the panelists and to any questions that the members of the audience might have about this plan. But most importantly, I'm just looking in the audience, I see many familiar faces, in fact, from many different sectors and from many different walks of life. And I think the whole idea about combating AMR is that it's not just the responsibility of the government agencies or people on the panel. In fact, it's the responsibility of every one of you sitting in the audience, and I hope that from today's session, you can take home these messages about AMR and go transmit the messages out there to your friends, your family, your colleagues, and to the public as well when you go back to your different, jobs and in different sectors. Thank you.
Thanks very much, Vernon. I would just like to stress that the issue of communication is not to be underrated. We have an AMR program at the school. There's now a collaborative group with the hospitals, with doctors and pharmacists and modelers, epidemiologists, health systems people. And sometimes it feels like, as the Chinese saying, chickens and ducks talking to each other when we try to find a common ground to work on. Professor Fukuda, do you have any comments on what your fellow panelists have mentioned?
I like chickens and ducks. No, actually, I'd like to address a couple points raised by Helena. I think that, it's been very clear for a while that the acronym in the name antimicrobial resistance was a terrible choice. I mean, nobody understands it. The problem and the difficulty, or let me put it this way, there were two large surveys which were done, one by Wellcome Trust, one by WHO. And so it was clear people had heard it, the acronym. It was clear that people had heard the phrase antimicrobial resistance and knew it was a problem, but they didn't know what it was. And so a lot of people thought, well, it means if I take antibiotics, I become resistant. And that's the issue. But Wellcome suggested that we should move to something like drug-resistant infections, which on the surface is much easier. But the discussion has been that if you have passed legislation and done things in the past using another terminology, if you change that terminology, how much work do you have to go back to retrofit and so on? Can it be done practically and so on? So it's simply been a practical issue like that and no clear resolution, but it's been one of the interesting discussions on this. Another issue that you raised really was donors saying, where should money go, basically? And I think health always faces this conundrum. It's always, should we do this or should we do that? And the real answer is always we have to do both. If they're juxtaposed as an either-or situation, it basically ends up being a lose-lose situation. But money is not infinite, and so then how do you handle that situation? I mean, I think practically in many ways, if you have a problem over many years, taking a phased approach to using money, emphasizing something, and not posing it as an either-or is the way that we'll have to deal with something. And in other instances, it is simply making the case that more money is needed. Some combination of those. Civil society, completely agree. I mean, one of our lessons in Geneva was that in the beginning of the discussions, rather than wait for civil society to come to us, we actually actively went to civil society, both on the agriculture side and on the human side. And one of the interesting things that they said is that we have never sat together. We're basically human NGOs, or civil society, and animal ones. but we don't typically work together. And so this issue has done something interesting. It sort of brought us and forced us to talk about how do we look at things, and that's been very interesting. And the last thing about the role of accountability. Accountability is important. Accountability is also a stick. You need a carrot in addition to a stick and so on. And so we need both of those things for a kind of balanced approach, I think.
Thank you. Is there anyone else who would like to raise a question or comments? There are many experts here from the region. Some of you have also worked very hard on AMR in the region. We also have opposition party leaders here.
I think that's just because the minister left, right? Thanks, Liang, for putting together a really good session this morning. I just skimmed through the 24 pages of the National Action Plan. I was really impressed by how fast they put it out. But I noticed that there's a gap in terms of the rapid diagnostics. Because I think Keiji alluded to the point of the doctor at the coalface. So the doctor sees a patient who's sick, and they're hearing all these messages about AMR, about antibiotic-resistant pathogens, and the pharma reps are telling them, unless you use the broader spectrum antibiotic, within an hour your patient is going to die. So, the knee-jerk response is to use the most powerful antibiotic they can. And then, of course, the collateral damage is tremendous. So, I think we've seen this with some of the other disciplines, like, for example, with dengue. The rapid diagnostics for dengue have really improved pickup rate and early management of cases. So I'm just wondering whether we could have more emphasis on, rapid diagnostics for antimicrobial resistant pathogens so that the clinician knows who needs broad-spectrum antibiotic and who can get away with amoxicillin.
Professor Fukuda or Vernon, do you have any comments?
Thanks, Paul. I think this is one of the perennial issues that has been discussed at many global AMR fora. The availability of a good, cheap, sensitive, and specific rapid diagnostic in a clinical setting. Unfortunately, AMR is not quite like dengue, where it's dengue positive or negative. You need to know, is it a bacteria, is it a virus, and better still, what kind of antimicrobial antibiotic agents it is sensitive to. And therein lies the challenge. There's currently no such test that's available, and we've talked a lot about research, and this is something that researchers are looking into. But until we have a test that it's cheaper, and a lot of times, when these new tests are launched, the test might be more expensive than the treatment. So how are you going to justify that in the clinical practice? So you need then time to develop these tests, and if they do come to market in a large way, then yes, we can address those problems. Until which time, then there's a lot of clinical acumen that's required to try to discern between the need for antibiotic use and not. But you're absolutely right. At some point in time, through research and through new discoveries for diagnostics, we hope that we'll be able to achieve such tests. And it's not just in the medical field. I think in the veterinary field as well. Not to forget, for example, pets. They do use quite a bit of antibiotics, and in other instances where such diagnostic tests may be useful in both the outpatient and inpatient setting as well. Keiji.
I can perhaps just add one more comment on the new techniques that are becoming available for molecular profiling, and next generation sequencing is allowing us to simply see what genes are there and not having to first of all grow the organism and then find out what it is or what antibiotic it doesn't grow against. So I think we are getting there in terms of molecular techniques for characterising and not having to do the longer time studies. And also the cost of sequencing is dropping dramatically, and there are sequences that small ones that you can even fit in your pocket and carry with you. So we're getting there, and it will be much more encompassing rather than needing to say, is it a virus or is it whether it's a Klebsiella or an E. coli or what it is, but it's simply what gene is there.
To add that, a lot of these technologies right now are available in developed or high-income countries. What we actually need is simple, easy-to-use tests or other methods that can be really implemented in the field in lower resource settings where a lot of the antibiotic use and abuse is occurring. So that's another sort of dilemma where, if you're in a top hospital, academic center in high-income country, you have access to some of these technologies. It's costly, yes, it is possible. Now, how do you replicate all of these in a low-income setting? I think that's a challenge that we are facing with as well.
There are two global contests that I know where the point is to develop a cheap point-of-care test that differentiates between bacterial infections and other types of inflammation. One is the Longitude Prize, which commands £10 million, and the other one is a prize fund from CDC and the White House, and I'm not sure whether Trump has rescinded that. But nonetheless, the Longitude Prize people from Nestle were in Singapore, and they also met with our research institutes to see whether there were any takers who were interested in participating in that prize. I think we had none from our research institutes at that point in time, but Paul, I take your point, we may have to see whether we can push more on this area. Any other questions or comments? Brenda?
Thanks. Short this and clarify that I don't belong to any opposition party. Thanks very much, Professor Conway, for bringing up about rapid diagnostics. I think rapid diagnostics for gram-neck resistance are already here. They're not cheap, of course, but they're available. And I'm sure this is where it would be nice to have people doing the health service outcomes research to try and analyze about cost effectiveness. Our hospital has been trying to put in a program to do rapid diagnostic tests because the technology is very good for carbapenem-resistant Enterobacteriaceae, and we've been held off for about a year because of funding issues. Right? So this is another area where, on one hand, the tests are available, people have to try and analyze to see whether it should be done, and if you're very serious about trying to arrest the spread of one aspect is CREs, I think we shouldn't be waiting too long because the bus may really happen. The other thing I have to, of course we can have rapid diagnostics for very resistant organisms, but another way would be rapid diagnostics for the GP. We're just trying to decide whether it's influenza. And that one, I don't think it's very expensive to test. If you get that done, maybe you could actually reduce the use of antibiotics, just as Paul says. The doctor hears about patients who have their missed and then there's a big stink with the diagnosis. So I think there are certain rapid tests which are not that expensive, which can actually be made available to the primary care practitioners. The other issue I have with Vernon actually is the idea of surveillance. And we all ask for more surveillance, but at the same time, I think ministry needs to look at the issue of surveillance and reporting. If you tie it into pay for performance, then it becomes a stick that if I pick up things and diagnose things and report them, unfortunately I don't get labeled as someone with higher rates of symptoms. So it's a very difficult balance. And lastly is to the communication. Some of that resistance that we see is possible from a food source. And yet I challenge any of my ID colleagues here when they explain to their patients where they have got the antibiotic resistant bug from, to be able to bring out the issue as well. Maybe it's a chicken that you ate or something else, because I don't think that our public is quite ready to hear that yet.
Vernon, would you like to?
I think we noted your comment about the surveillance issue. We are currently in discussion with various stakeholders, and we're looking at, as you can see in the plan, strengthening various programs moving forward. Regards to your issue about the rapid diagnostics again, I think this is a very tricky sort of point. And in certain settings, perhaps like you've mentioned, say GPs using flu rapid diagnostics, it might work in say certain temperate countries when you have a huge flu epidemic at that single point in time, where a rapid test for influenza might tell you whether it's influenza. You don't need antibiotics, or if it's not, and it may be bacterial. In the local setting, especially in the tropics, where you know that there's transmission of all kinds of different viruses and bacteria, being negative for flu doesn't mean that you need antibiotics, because it could be due to a whole host of other viruses, RSVs, coronaviruses, whatever you name it. So unfortunately, there's still no good test. I think Paul has brought it up quite eloquently that we'll need something perhaps a little broader that can be used in a variety of settings. But you're absolutely right. For discrete settings, there are tests available that could actually help the clinician in making this decision.
Professor Fukuda, Sorry,
Oh, sorry.
Helena, go ahead.
I just wanted to add to that. So I think it's also very important when we think of the adoption of new technologies that we also think of the perspective of the professionals and the perspectives of patients to actually use them, and for the healthcare professionals also if they're willing to adopt them. So one of the areas that we're really kind of suggesting in the school is also to look at behavioral change interventions, because for some of these areas and some of the preliminary interviews we've done, culture is a key issue, and people are really like, they decide to use certain things, and there need to be kind of more interventions to understand how they would be willing to change behavior. And I think this is an area that not only for AMR, but for other topics, we really need to address. We need behavior change techniques, but we also need to understand much more about the patients and the professionals. How do they want to see their patients, and how the patients want to relate to the healthcare professionals.
Thanks very much, Helena. I was going to ask Professor Fukuda what you felt about this incentive carrot stick issue with surveillance and hospital compliance. I know that the UK fine its hospitals £100,000 for every single case of methicillin-resistant Staph aureus bacteremia. But I think there are some concerns locally in the region that it might lead to gaming by the hospitals to try to avoid this situation.
I mean, I think in general that you need both carrots and sticks. You know, you can't do things with just one or the other. I think that the issue, though, is that depending on where you are, the balance between carrots and sticks differs and so on. It goes a little bit to your point. I think that, you know, the issue of proper treatment is not just one of diagnostic tools. I think diagnostic tools are important, but it's really that patient-doctor interactive system which is really critical. And I think in many ways we don't understand that. We certainly don't understand it in different cultures and so on. And so I think that I see this as one of the big issues. And with the emergence of the idea of precision medicine, for example, and all of the issues about digitized data and so on, it will be more and more possible to get to a quicker practical answer about what exactly is the decision-making process for how people end up getting treated, either rightly or wrongly. So it will include technologies, but it will go way beyond that, I think.
David?
Hi. I mean, I'm kind of trying to put this out in response to Paul Conway's comment. I think, you know, point-of-care diagnostic technology are all very exciting, but to solve the problem of the majority of antibiotic use in human health, which is primary care or common cold, you don't actually need rapid tests. Now, the National Action Plan focus on Singapore. I mean, good medicine is about patients, you know, talking to the patient, doctors talking to the patients, advising them so that it's time, and it doesn't get better, come to see a doctor, and that costs money. So, healthcare, you know, system financing. I mean, this is about, you know, the sacred cow. You know, the way our primary care is set up, will that facilitate or impede good antibiotic practice? It is something that the panelists comment on, and you know, I mean, this has been a sort of the way our primary care is set up in the last 50 years. It won't change overnight. But if no change occurs, we'll expect anything to improve. If we throw more money at it, will it work? So I seriously think we need to think about sacred cows.
No comments? Yeah. We seem to have done the dangerous thing of veering back into human medicine and hospital infections, which, while it's important, it's not all about antimicrobial resistance. Are there any questions or comments regarding to animal or one health?
All right. I just want to share. Do you know that we do already have all the technology for multiplex detection of different pathogens and bacteria? You can distinguish. It's in your hand already. It's a matter of execution. In Singapore already has. You have to remember, you already had, but you need to execute it. As Professor Keiji Fukuda mentioned, we have to do both top-down and bottom-up approach. If the leader doesn't execute this, in the bottom part, everything is scattered. It's all segmented. So you have a diagnostic, you have software, you have a nice interface, between the patient and as well as the medical doctor. So we can think about patient-oriented engineering medicine to implement this. But you have to have a clear decision from the top leader to execute this. And you worry about money and manufacturing. Actually, whether you believe or not, is in your campus. You have to remember in NUS campus that it is be ready to be used, but we have to integrate them together, both public health and clinician, as well as engineer and scientists to finish this implementation. The key elements already exist. Thank you.
Thank you.
Yes, my name is Ong Siu Huan from the industry. My company is involved in developing molecular diagnostics exactly for identification of pathogens by PCR, as well as antibiotic resistance mutations by PCR. But I didn't come here to do a sales pitch. Although what Luke just alluded to is very true, the technology is there, and I think the whole cost benefits, cost effectiveness need to be looked at more thoroughly beyond, a new PCR test versus ELISA test per se. This costs X number of 100, this costs less than 100. I think the cost benefits were to be looked at differently. But my main question really also came from the comment by Prof. Fukuda that to treat a patient with TB which is pathogen resistant, that amount could be as much as 100 of other patients whose infection is not antimicrobial resistant. I think this is a very striking number, which brings me to the thinking that maybe to zoom into the antibiotic or antimicrobial resistant species are far more important, and this was also a point alluded to. Therefore, I want to look at it back in our home ground. We always want to start to care for our people in the home ground first. In our environment, do you think it's worth to look at specific unique antibiotic or antimicrobial resistant forms in our environment, while we also look at other environments? Is it justifiable to have research efforts, commercial research efforts to look into screening, next generation genome sequencing projects to identify resistant mutations in our environment? Is this problem big enough?
Professor Fukuda.
Can you just clarify, when you talk about screening genomics, are you talking about the microbial genomics or human?
Genomes. For example, in HAI species from hospitals, is it justifiable to look into projects to zoom into this sort of resistant species?
Yeah, I think your question is also taking it outside the hospital, because we've had a few questions within the hospital environment and your hospital setting, and your question is also, should we be surveying the environment and the water and other sources? And of course, and I think this is what Professor was saying earlier in his presentation, it's a holistic approach of the entire, the planet's a little bit large, but to take Singapore, it's not just the hospitals, because the hospitals are having people who already are either immunocompromised or have surgery. They've already had a suppressed system and they're unhealthy. They are more predisposed to taking in the antimicrobial carrying pathogens that are there. But within the environment, there are microbes everywhere. And looking at the incidence of antimicrobial resistant genes in the environment, in our food supply, it can't be ignored.
Yeah, I agree. I think there needs to be extensive more research in this area in order to answer certain basic questions. I think looking in this area to look for specific patterns which are unique to Singapore is not really it's not the right way to think about solutions for Singapore. Because I think that what you find in one time frame is likely to change later on as a specific genetic issue among bacteria. But I think that Singapore has a tremendous ability to pose questions and answer them here, because you have the systems and you have the technology and you have the people to do it. It's really just initiating, I think, the right studies, but I think it could be fantastically helpful at the global level.
Thank you very much.
Thanks. Tim?
I thought a moment ago you were trying to get people to talk about the animals, so I thought I'd talk about the animals slightly. But I have to say I agree with David that technology promises it's not going to deliver for ages. Why can't the doctors just be trained to withhold the impulse to give antibiotics, which he mentioned a moment ago? So something I sent to David about 2 years ago when he was putting up some grant was, well, if I were in charge, what I would do is if I were in charge of Singapore, which I'm not, I'm not allowed to be in charge of anything, but I would say to the people who import food, right, we're going to measure how much antibiotics in the food, and we're going to give you a target. This time next year it's got to decrease by 5%, next year 20%. So that you could have an incremental stepwise or reduction in the amount of antibiotic that's coming into our system and resistant organisms coming into our system. You know, exactly how much is antibiotic in the food or resistant organisms, I don't know without measuring it. And then I suddenly thought, well, that's fantastic, and over time you could have decreased the time bomb that is in all of your guts, which is just a little bit of resistance. It doesn't matter until you're sick. Could we reduce that? I don't know. Then I thought, before that happens, I'm going to set up my own farms in some islands around, so I can then sell my antibiotic-free chickens to Singapore. Thank you.
I'm not sure if we do have members of the AVA here. I don't know if they wish to comment on that. What I understand is that the meats and the products that come to Singapore are relatively free of antibiotic residues, and the inspection makes sure of that. If you're talking about the use of antibiotics for growth promotion, I think that's a separate matter. But Vernon.
So, I mean, our colleagues from AVA here who can talk a little bit more about this, but as Liang has mentioned, the AV does test the food that comes into Singapore for antibiotic residue. And for the most part, the food that's present in your food chain is antibiotic free. Now, the resistant bacteria, okay, in the food. Sure. Yep. So the problem is actually more upstream, because the use of antibiotics during food production, which happens, as you've seen Keiji's slides earlier across the world, is that the prevalent use of antibiotics will drive a lot of those resistant bugs that will then reside in the food or in other parts of the environment. And then lies the problem. So technology can help to address this to a certain extent.
Before you go on, that's exactly what I said. We've got to say you cannot import food into this country that has resistant bacteria in it. You do that, you're not allowed to. You measure that. You've got beta-lactamases in there, you've got carbapenemase in there, no go, send it back. I mean, why not actually start getting real? Everybody's pussyfooting around. Nothing here is new. Nothing.
I'm not sure if our colleagues from AVA wants to respond to that. I'm not sure if that's
and your comments are skirting around what I've suggested.
Sure. I'm not sure if that's feasible or even measurable, but I don't know. Any colleagues from AVA who want to respond to his suggestion? Yeah. Okay. I'm going to pass this mic to the audience.
I guess when we first talked about it, sorry, I'm Himo from AVA. I think this question about whether we can reject anything with AMR, I think that's a very, what I would say is a pretty draconian way of doing things. Yeah, I mean, it affects the food supply for us. 90% of our food are imported. Okay, meat probably not as, probably 100% of our meat are imported. So I think that's something that we need to look at. I mean, whether you, in fact, do you really want to go that way? I think that's something that we have to seriously take a look at it. But first of all, I think everything has to be science-based. Okay, I think we need to study this issue carefully. You know, what is the AMR detection in meat? What's the impact? What's the significance? I think that's something that we need to study. And as you've seen earlier on, I think this food security issue is a problem for us. I mean, for Singapore too, even though we can afford it, we don't produce a lot of food in Singapore. So we do rely on our import.
I think this is one of the most interesting issues for AMR right now because there are a couple of different things which are going on. I was talking with someone with Nestle's recently, and they said, we are the largest food company in the world. We are involved with only 2 or 3% of food in the world. They said the business is enormous. And one of the changes going on is that, you know, when you go to a grocery store now, you will see antibiotic-free, whatever it is, some kind of meat, chicken or something like that. And if you are walking in a city, can be New York, you will now see posters where restaurants will advertise, we do not sell or we do not use antibiotic-grown meat. The question which has come up is that how much do people talk about this is important versus how much will they actually vote with their pocketbook? So will they buy things which are a little bit more expensive if it is considered antibiotic-free? So you have this enormous economic questioning going on at the level of consumers. The reason why it's so difficult in Codex is because what you're talking about is really the movement of food across countries, a big trade issue and so on, which is a very high political issue and stuff. And it is, I think, very hard for countries to put unilateral demands. It's possible, but it's very difficult. And countries are always worried about whether they've sort of undercut themselves and hurt themselves by taking that step. But I think that in the end, for me, I believe food is going to be one of the drivers for AMR and why it's going to get addressed, because I do think that the concentration of issues about food safety, adequate food, food trade, it's an enormous money issue and it's enormous social confidence and trust issue and so on. So I think that it may not get addressed as directly as you're suggesting can be done, but I do think that it is going to be almost the biggest driver for change over the next decade.
Thank you. You had a...
Sorry. Just that. Since we're talking about food and to give the sort of animal health, animal industry some credit for this. So I think a lot of the upstream food production and use of new technologies can also be brought to bear. I mean, one very good example is AVA working with the fish farming industry in Singapore and development of fish vaccines. So this morning we just met with Dame Sally Davis, who, as you all know, is the Chief Medical Officer of the UK. She's a very strong proponent of AMR, and she was very interested in the fish vaccination technologies here used in Singapore, where individual fishes, I understand, are vaccinated, and because of that, they are resistant to a lot of common infections and therefore do not require a large amount of antibiotics to be given during the fish farming practices, where in a lot of other places, when they farm fish, they will actually bucket loads of antibiotics to try to reduce the infection rates in this very high density population of fish. So simple technologies like that are available locally and are available in many other areas as well and can actually be expanded and reproduced in different settings. So I think we should look and at technologies that are currently available and sort of think out of the box for new solutions. But I think thanks for Tim for that very interesting suggestion. We'll certainly look into how it can be done if it can be done.
Cherise.
Yeah.
Kim Lee, sorry, just a moment. This gentleman has been raising his hand for quite a while.
Okay, thank you. I'm Jyot from Minister of Public Health, Thailand. I just have 2 points, maybe to list for the panels, for the panelists. One is, should we try to make link more, maybe for all global public health or priorities, including non-communicable disease, AMR, and climate change? Because I thought that 3 issues are somehow interrelated. Giving examples, like NCDs, we know that NCDs diabetes and treated cancer patients are more susceptible to be infected, and then need for treatment for communicable disease. And also for climate change, climate change makes food security is a major issue for government and industry, and that is being to the Professor Fukuda says intensive farming. So that is also related, and also climate change brings more emerging disease. And when we have emerging disease, it means we need to have more actions. Sometimes, for example, in Thailand, when we have a flu pandemic, we also found evidence that more antibiotics be used for the patients coming to hospital. And that also brings to more antimicrobial resistance. I try to think why we're not trying to link up together all NCDs, climate change, and AMR, because first is that all public health professionals who need to dealing with these all priorities are the same group of people. We need to have, and also this is the problem of the same health system, same healthcare system, and we are competing the same health budget, global level and regional level, and also in domestic level. And I'm trying to look at the WHO's global work, action plan for antimicrobial resistance and using NCD terms. It's come up with 0. So I'm not sure. Every country is now having a national NCD action plan, and now we have national antimicrobial action plan. Any link between these all public health priorities? So that is one of the issues that maybe I like to hear from panelists. The second one is that Professor Fukuda having one slide saying you have 2 rules that I think we should keep. One is never break the trust. In Thailand, a few months ago, I heard that there was a survey from private groups who are doing the survey on organic food in Thailand, and found that half of organic food labeling as organic food in Thailand, more than half of them are contaminated. So it's not true that they are real organic. Even they are more expensive, and people purchase them because they truly believe this is good for health. So I don't think we can get more participation from civil society for other sectors if we try to keep them trust about the system, for food system, even healthcare system. Food system is the things, the current food production protocols are safe. They don't need to make any action trying to make it better. Also, if they believe that over-diagnosis and over-treatment in healthcare systems that are currently providing are safe for them, so there is no need to make an action to reduce over-diagnosis and over-treatment. So that is maybe, I'm not sure, should we still keep that rules? I mean, never break trust, or we trying to a little bit of breaking trust for them to make more challenge to the government, or to why government will not take any action if the public is not less this concern. So thank you.
Professor Fukuda, do you have any comments on that? Are there too many national action plans for too many things?
Well, let me maybe start with the first question. I think, should we link? I think the interesting thing about characterizing, I won't even use the word defining issues, but characterizing issues is that in many ways it is a kind of iterative process over time. So if you look at how HIV was first defined and how it's later defined, it changes over time. And the reason why it changes is that we characterize things in a way which is useful. We characterize hypertension not because it's an absolute, but because it's useful to treat people who reach a certain degree of pressure and so on, and you see measurable benefits. So while we have big issues, if we make them bigger than is necessary, we also in a way paralyze ourselves. Once things get to be so big and so complex, we really don't know how to do it. AMR already has paralyzed really people for quite a long time. And in my private discussions, I have heard over and over again, we don't even know how to start on this issue. It is simply too big and too broad. So I think that while conceptually we should point out how all these things are linked, because they are very much linked, I think that as a practical issue, and right now I spend most of my time thinking about AMR as a practical issue, how do we simply move ahead with it? I would try to define it so that we can actually take practical issues, and so my roundabout way of saying link conceptually, but think about practicalities a little bit differently. The truth or the point about breaking trust, I don't think that I don't think that you can play with trust. Trust is something that if you have it, it is the most precious thing, because it's what is needed for all important discussions, whether you are a patient talking to your doctor, or whether you are people thinking about whether your government is believable, or whether you pick up a food and it says organic and then you read a report and say, no, in fact, it's contaminated with a lot of different things. It was not truthful and so on. And I think that you can't, it's so hard to go back to a kind of situation where people will believe you, but they have to believe you if you're going to do things. And so, no, I believe that principle is really a principle. It is beyond a observation. It is simply a principle that is important. I do think that it's important for governments, if things are going to be labeled, then it is the government's responsibility, in part, along with the food producer and along with the company, to make sure that what it says on the label is truthful. It is a little bit like safety. Safety is not the responsibility of regulatory agencies. It's the responsibility of the companies, it's the responsibility of the process, it's the responsibility of the regulatory agencies and so on. So you've asked some very philosophical questions, a little bit of a philosophical answer.
Helena, you have some idea of the health systems research of everything?
Yeah, I wanted to mention, I think it's a key topic, and it's multisectorality, and we've always struggled with that. And I think we go back to the Almata Declaration, that it's going to be 40 years next year. One of the key components is to work in a multisectorality, and I think hopefully it's going to be revived because of that, and also because of the SDGs. I have to admit that I also work on NCDs and action plans. I've been involved, but between all of you, I keep it sometimes a bit of a secret between the AMR community, because otherwise they would feel like, oh, I'm not committed to NCDs. So this is only an example of how much we work on silos. The other issue is donor fashions. So donors, they like to put their money into one thing. So this idea of health system strengthening, I'm not even talking about animal health, it's a challenge. So most of the donors give 1%, 2% to health system strengthening, and then they prefer to put the funding into conditions. So this is another area that we need to move forward. SDGs promises to be one of the key solutions, but my little experience that I share with you with doing interviews in the region, I've talked to lots of actors, people working in NGOs, for the ministries, and they all confess secretly, we don't know how to do it. So we work in our field, either it's health or it's poverty reduction. How do we actually manage to all work together? So the intentions are there, and I think the SDGs is a huge opportunity, but we still need to do a lot of work on that.
Thank you. Kim Lee, sorry to keep you waiting.
I almost forgot my question. No, actually, it's about public education. You know, it's very difficult to convey what is antimicrobial resistance. But you know, in the primary care, you have not the GPs who give the antibiotics, but the patients who want the antibiotics because they think it will help them to get better faster. So I was thinking that, you know, maybe the people in the government sector, they could label. I recall a slide shown by Professor Fukuda about the spread of or the use of antibiotics in different countries. And there was a very big circle in China and smaller circle in India. And I was wondering why smaller in India, but I think it's to do with the practice of animal husbandry. Perhaps a lot of Indians are vegetarians. They don't eat so much meat, but Chinese and Singaporeans, we do eat a lot of meat. So it's difficult to control at the import level, but perhaps within our country, just like the way we label bread, trans-free bread with a hard sign. How many laymen understand the word trans-free fat, how many understand that? Nobody, but if you see that sign and you know that it's trans-free, it must be better than the one that does not have the sign. So I'm just thinking if the meat, which is the source of the farms that use antibiotics, could be labeled by a sign that says antibiotic free. So this term antibiotic sticks in the mind of general public.
So when they see antibiotic free is better than antibiotic not free, then when they go to the clinic, they don't just ask for antibiotics because they know antibiotics must be something not so good, right? I mean, it's a matter of like behavior, changing behavior, because it's difficult to educate. I teach lipid in a tab, but even my students don't understand trans fats, you know? So how do people know what to choose? But it does drive behavior. And we can't tell our suppliers what to do, but we can tell our people how to behave. So I think it's a viable thing within Singapore. Yeah. Thank you.
Thank you. That's quite a novel suggestion. I've discussed antibiotic-free labels with my ABA colleagues a few times, but never an antibiotic not-free label. Do you have any comments?
I think the suggestion's really interesting too. But I think the difficulty with antibiotics is to say antibiotics is not good is the wrong message. I mean, really, antibiotics are precious, and I think it's that balance that we don't quite know yet how to communicate. Because if you need them, then they are the best thing in the world, and if you don't need them, then they can cause, other problems and difficulties. And I think that, I think that we don't really have the right communication tools and messages right now. But I think the second thing is that labeling makes a difference, but I believe in the area of food, if people show that they're willing to pay more money, if that's what it would cost to have foods which are grown without antibiotics, the industry itself will move, and selling practices will move, and trade will move, and so on. I think a lot of this really will come down to consumer behavior more than anything else.
Thank you. Vernon?
I think that's a really good point you brought up about sort of social behavioral constructs and what levers we can use to influence behavior. And I think one of the gaps that we have, not just locally but internationally as well, is that there are not enough studies looking at the social behavioral aspects of the use of antibiotics or of disease, concepts and things like that. So I think before we sort of just jump onto sort of individual ideas, which may be very good, I think we probably have to understand the social behavioral constructs first, then to see where we can target the intervention or best target interventions, based on the evidence. So this is something that I think would be a challenge to those working in the sort of social behavioral sciences sector to come forward and work with us to find out more about the levers that we can use to combat antimicrobial resistance in terms of communications.
Thank you. We have time for one last question. Olian, if you...
Thank you. Thank you for that wonderful talk, which is very thoughtful and philosophical. I guess my question is really for Keiji or for Helena in terms of healthcare systems. Because one of the challenges with antimicrobial resistance is the fact that it's happening in a system where there are some misaligned incentives. So, for example, in the Singapore context, doctors can dispense as well as prescribe, and therein is a potential misaligned incentive. But if you think about our region, I mean, in Singapore, antibiotics are only available by prescription, but we're certainly in a region in Asia and even in parts of Europe where, or in other places where you can walk into a pharmacy and get antibiotics without prescription. So while we can sort of tend our patch very well, we are porous. I mean, people go to Bangkok and can pick up medications there without prescription. And obviously, even when we look at trying to change that within Singapore, it would be a huge political, regulatory challenge, to take away, in a sense, some of the profit from GPs in prescribing, for example. And so we can't even begin to it's very challenging to try to tackle that even in Singapore. And certainly we recognize for many countries around the region that there may not be enough doctors. You can't let someone die just because they don't have access to antibiotics. So it's part of a much larger health system access issue. What are your thoughts about trying to tackle that? Because it feels like it's too difficult and too big. What would your ideas be, your thoughts be about how to tackle those issues and economic barriers.
Thanks, Bolin. I used to run a small private practice where I kept my own little pharmacy and would peddle antibiotics and other things. And when the expiry dates on those antibiotics drew near, there was always this temptation to try to find a way to move them away. So I get your point entirely. KG and...
I'll comment on the animal aspect, that in Denmark I made the reference when they were removing antibiotics for growth promoters, but they also reduced the profit that the vets made by dispensing them. So the vets, 50% of their income came from the profit from prescribing the antibiotics. By removing that benefit, that cost benefit, the use of antimicrobials as therapeutics dropped dramatically.
Vernon or Professor or Helena?
That was a very good question and a very challenging one. I think it's one area that we're thinking of doing more work on, and it's exactly the regulation of pharmaceuticals. And our experience, I mean, I've done a lot of more work in Europe, but so far we have a couple of projects in Pakistan and Cambodia that they've just started, and it's one of our key objectives, to look at the way that the antibiotics are being dispensed. And in Cambodia, we are focusing on private pharmacies, and in Pakistan, more generally within the health system. But we don't have a clear answer yet on what are the drivers and whether regulation works or it doesn't work.
Maybe just to add my 2 cents on this, I think that it's partly a health systems issue, and it's also bigger than a health systems issue. I think it's a health systems issue. Some things are clear. I think that profit does drive the distribution and movement of antibiotics and so on. And so I think it's one of the things which, has to get tackled. Even in communities without formal health systems, selling antibiotics from one neighbor to another person, doctors selling to patients and so on. So I think there are clear things that you can do as a health systems issue which ought to be done. And I would start there. But I think in the end, regulation and those things will get you so far. While you were asking your question, I was sort of trying to think about what are things that we think about really differently now, which is beyond regulation. And so I think the image of how much the oceans have plastic in them, and I think the sense of unease that plastic bags and wasted plastics are really destroying the world is now beginning to seep into people. So I think that recycling, there aren't formal rules on having to recycle, but more and more people don't feel good if they're not recycling things and doing those things. And I think that just the whole issue of climate change, the idea that we need to back away and go to cleaner forms of energy, whatever that may be, it is sort of now at a visceral level and so on. So I think that, for me, the kinds of things that you are raising, we need to look at some of it as a systems issue and act upon them in terms of hard regulation and hard rules. I do think we need those things. But at the end of the road, the reason why I keep coming back to this idea of a social concept is that, there's no laws which mandate how physicians should interact with patients, but HIV completely changed our paradigm that, patients should be able to get more information, should be able to ask questions, should take a role in their treatment. And a lot of that was pushed by the enormity of HIV sinking into the world. And I think so. I think we need both of those things. And so, anyways, that's how I look at it.
Thank you. Are there any other final comments from the panelists?
Yeah, perhaps just to give a couple of sort of last comments about the National Action Plan. So it is a living document, and it is something that it's not just developed by just the working group alone. It will benefit from a lot of inputs from members of the public, members of the audience. So if any of you have any different ideas about how we can improve on our action plan, how we can combat AMR better, and if you want to join us on this quest, please feel free to come and approach any one of us, and we'll be very happy to hear your views and to work with you closely on this. So I really hope that this session provided you with at least some insights into the problem at hand and how we can address them. and we hope to work with you, across the next several years and beyond to try to address this. It's not a problem that can go away within days. It's going to be years or decades. But if we don't start now, we'll never be able to address this ever.
Thanks very much. Helena, you want to say something?
Make also a final comment on the National Action Plan. I haven't had the chance to see it yet, but only a suggestion or kind of a reflection on experience from other national action plans that I've been involved in. So I was 10, 15 years ago, I was very much involved in national strategies for assuring quality of healthcare. And I was quite young and I was quite naive, so I got involved in trying to map all the strategies that exist at the European level. It took me 4 years to do. And what I learned from it was that most European countries had beautiful national action plans to assure quality of healthcare. Once we get into the implementation stage, that's when it was the challenge. And I have to say that as the number went to 10 countries having beautiful plans and nothing being implemented. So for me, this is a word of caution that of course, I'm sure Singapore is going to implement the plan, and I'm sure the national plan is going to be very beautiful, but we also need to pay attention to the implementation stages.
Thank you. Patricia, do you have any last?
Just to finish up on the comment, we don't want to scare people about antibiotics because they do a very good job. We need them. And spin off a little bit on the vaccine aspect, because you mentioned vaccines are an alternative, but vaccines also have had their negative aspects, and there are many families in Australia that don't vaccinate their children, and it's because of the scare of the negative impacts of it. So I think we need to be careful not to scare the consumer about antibiotics.
Thank you. Thank you very much. Professor Fukuda.
Yeah, well, first I want to thank the Dean again for the invitation to come. It's been enormously enjoyable in this discussion, and thank you, everybody. I think the last point I would simply like to make is that, again, another observation is that policy and decisions in the world are often not made on the basis of evidence, but lack of policies, lack of action is always justified by saying there's not enough evidence. That's invariable. And I think that Singapore genuinely has the capacity to answer and ask questions that very few other places can do. You can actually do that here, and I think that the city is really hurtling into the future in terms about how it looks at healthcare, at the systems, and how it integrates many things. And I would really, really like to urge you to ask those questions, because I do think that you can ask questions here that are just theoretical in most places and actually come up with the answers in the next 5 or 10 years. And so I would love to see that happen.
Thank you. With that, we'll call this session to a close. Please thank the panelists for their time.
And with that, we've come to the end of today's session. Before we adjourn for lunch, I would like to request the panelists to take a group photo. And once again, we'd like to thank Professors Keiji Fukuda and Patricia Conway, as well as Associate Professors Suli Young, Vernon Lee, and Helena Legido-Quigley for their insightful discussion on antimicrobial resistance from knowledge to action. I hope everyone also enjoyed the session as well, and learn a lot.